Thank you for having me, everyone. This is a bit different talk than what you've been hearing since yesterday and today. I come from technology background, and my topic is talking about artificial intelligence in healthcare and the advances that we've seen in the last few years, particularly. I'm representing Dozy, which is one of the companies that are working in health tech and patient monitoring and triaging systems and warning systems. And I'll discuss about the solution as we keep going ahead. So before we discuss the solution, a small glimpse of the problem, and this is nothing new. Most of you being in healthcare already know about this. In our country, the healthcare system has been burdened for a long time, even pre-COVID, and COVID just expanded all the cracks and even amplified it way further. Uh, in our countries, in different parts, we have nurse to patient ratio ranging from 1:12, 1:15 to 1:40 even. On the other hand, WHO recommends that in a high dependency unit or a step down unit, you should have at least 1:4 ratio. For specialist to patient ratio, we have something around 1:5,000, which is essentially translates to for 55 million cardiovascular patients in India, we just have 5,000 or so cardiologists, 50 of them almost here today and yesterday combined. Every year we add few hundred cardiologists to our, as in to our manpower or to our doctor force in the country, and every year we add millions of cardiac patients as well. So this gap is very disproportional. This is something which leads to our healthcare infrastructure being broken. And this is, as I said, this has been there for a long time. It's an infrastructure issue. And this is not something which is getting really better. Although we're establishing more medical colleges, we see more and more cardiac surgeons, cardiologists, different specialists coming up, more nursing power that is coming to our manpower or workforce in the country as healthcare professionals. But these numbers are getting worse. Why? Because as simple as we have, for example, we have approximately 2 million hospital beds in our country, both public and private combined. In the next 5 years, we've decided to double these, but we don't really have the manpower to man these beds. We are definitely going to double the infrastructure, the number of hospitals and the number of beds, but we're not going to have enough humans or healthcare professionals, both in terms of doctors and nursing staff, to actually cater for these beds and these patients. And in this time, we have to look at the problem a little differently. We have to see how technology can help here. Uh, this gap that is ever widening, can technology help bridge it? And if yes, how? So artificial intelligence plays a vital role in essentially aiding or actually automating a lot of efforts that are manual in nature, that can be automated, and then the healthcare professionals or the humans in collaboration can focus on the care, compassion, and actually the intelligence part of it. One such solution, and this is just one such solution, we have multiple solutions across different companies and different researchers that we've seen. For example, artificial intelligence in imaging particularly taking up really well in the last decade or so. But we decided to look at it in a different manner, right? We thought, we went into remote patient monitoring, and this is where one of the solutions that we came up with was to the problem that monitoring right now is very manual. Of the 2 million hospital beds that I spoke of, only 100,000 hospital beds, 1 lakh hospitals, 5% of the hospital beds are just ICU beds where you have continuous monitoring available, a 1:1 or a 1:2 nurse to patient ratio, where there is a continuous or critical care outreach being carried out on a daily basis or on an hourly basis. On the rest of the beds, we have different protocols in different parts of the country. In some cases, we have the nurses taking manual spot check readings every 4 to 6 hours. So we have 4 readings or 6 readings per patient. During your rounds, you would just see on a piece of chart paper that these 4 points marked out. Our theory is that this is nearly not enough for critical care outreach. It takes a lot of time. We've done a time, as in a time analysis, and taking that it takes 7 minutes per nurse on a particular patient to complete the set of readings, put it on a paper, and file it in a file. So 42 minutes per patient per day is something which is very high. Can we automate this process without major intervention from the healthcare professionals and major intervention from the patient itself, so that we can ensure the compliance is higher? So we've designed this product that goes under the mattress. It, in a contactless manner, collects vital signs, heart rate, respiratory rate, heart rate variability, even blood pressure to a certain extent now, and basically feeds all of this data into an early warning score engine, which is AI powered and which decides to escalate any sort of alerts to the healthcare professionals in time, so that an intervention can be triggered, whether it's shifting to ICU, whether it's shifting to whether the patients are at home, whether it's triggering an intervention for a consultation, and so on and so forth. This is how the data looks like, and that is how the patient looks like. So all the patient that he or she needs to do is just sleep on the bed, do nothing else. There is no compliance required as such, and all of the data on the left hand side is something that is available to you remotely. Whether the patient is at home, whether the patient is inside the ward, you can access the data at any point of time whenever there is an alert triggered from any remote device that you have, your laptop, your smartphone, and it's very easy to handle. This is the science behind it as well. So the science is called ballistocardiography. Ballisto is movement, cardio is heart, graphy is measuring. So it's essentially measuring the movement of the heart. This is a very old technique. This was actually invented in 1877. But a lot of people lost interest in BCG after ECG came in 1903. Primary reasons, there's a lot of noise in data. The data is not that standardized, so it's not really that useful to me, is what the healthcare professionals at that point of time thought. But in the last 2 decades or so, with the advancement of machine learning algorithms, digital signal processing, and computation power that we've seen on the cloud, we can now harness this data on a continuous basis without an intervention or without a person looking at it all the time 24/7. A machine can look at it and trigger if there are any anomalies or abnormalities that we find. We essentially extract the cardiac signal as well as the respiratory signal out of that, and then we carry on with multiple set of analysis to figure out multiple information, non-contact blood pressure, even to a certain extent. You would see in the coming slide the research that we're working on. We've just launched this. So we've been present in over 5,000 hospital beds during COVID time. We've monitored more than 60,000 COVID patients in these connected HDUs, connected high dependency units, where hundreds of hospital beds inside the ward are being monitored by a central location inside the hospital by a couple of healthcare professionals. And this is how the critical care outreach was being driven in these hospital beds. And of these, almost 60% of these beds are in public facilities as well. So we've proven that technology, if made properly, can actually go in remotest of the solutions or remotest of the places and can create a difference. We've been able to trigger early warnings or early intervention in these COVID wards for more than 3,000 patients, where they were triggered either for an ICU transfer or given oxygen on time or given a ventilator support on time. But now we're launching this connected heart care or cardiac care program, which you would have actually seen on our stall yesterday and today as well. The idea is that the patients after a significant cardiac event, a heart failure event, or any event that when they're post-discharge or when they're discharged and they actually go home and they're still not at their baseline for the next couple of weeks or next couple of months, they can be put under continuous monitoring, and a daily triage can be triggered every day. Based on the daily triage, there can be interventions or escalations that can be delivered to you after full investigation has been done, with the facility of a 12-lead ECG and other sensors like temperature, blood, NIBP cuff, SpO2 sensors, all of that data being combined together and being given to you on time. And the patient can actually be readmitted on time before a second event or a second major event occurs. All of the data or all of the care command center happens remotely all over the cloud. So all of the data is actually available to you at any point of time, whether you're traveling, whether you're in your clinic, or whether you're in your hospital, at just your fingertips on your smartphone or on your laptop. The basic or the major part behind this program is essentially an AI engine that keeps on crawling through all of the patient's data, establishes a personal baseline for that particular patient, and keeps monitoring that patient. Whenever the data of that patient or vitals of that patient leave their baseline or go beyond the baseline, there is a triage that is done, and the patient is categorized either into green zone, amber zone, or red zone, and that is when an intervention is triggered. All of this obviously comes with a lot of concern that we're moving a lot of this health sensitive health information and data to cloud, and whether it's secure or whether it's private enough or not. We've taken major steps to ensure that it is. Even just in last month, we've been certified ISO 27001, which stands for Information Security Management Systems. So our systems are very secure, and we've taken care of all data privacy guidelines that are available. The data is very secure, and only with authorized credentials, only and only then you can actually get access to all of the data. The data ownership belongs to the patient in case of the home care, and to the hospital and the doctors in case of hospital care. This is one case study that I would love for you guys to see. It's a couple of minutes of video. This is one of the first case studies that we did in our home, as in our cardiac connected care program at home. When and I would love to play this video, but this is a case study where a 60-year-old lady got the device for her 80-year-old mother, who used to stay alone and was adamant on staying alone. And to track their vital signs and as in to track their health, she had tried multiple sensors, multiple variables, multiple times, multiple solutions. But Dozy fit perfectly there because of its non-obtrusiveness. It went under the mattress. It did not change the lifestyle of the person at all being monitored, and did not bother them at all, but still was able to trigger for an event. I'll just quickly play this.
It's been 5 years since my father passed on. And the only regret I've had in life so far is that I haven't been able to spend time with him. I thought I'd do that with my mom, but she didn't want to change things and preferred living alone. So I was always looking for a way to ensure that my mother is okay. And Dozy helped me achieve that. There is no stopping my mom when she sets her mind to do something. She'll do everything without thinking how working so much will affect her health later. So that's why I got her Dozy, so I could keep track of all her vitals without disturbing her. With the updates I was getting from Dozy, I knew everything was fine with my mom. But one day, I got an alert. When I asked her, she dismissed it. She said maybe I was just working a bit too much, but I couldn't ignore it. So I spoke to my doctor and he said we could run some tests on her. Thank God we did the tests. The reports revealed that she had some abnormal heart rhythm and she required a pacemaker to set it right. The doctor said we were lucky to catch this so early, because even a minor delay in that situation would have been catastrophic. And Dozy gave me what I wanted most: more time with my mother. I sleep peacefully now, knowing fully well my loved ones are always safe with Dozy.
And a fun fact in that video, the characters that you saw were not actors. They were actually they were real people that were using Dozy, and all the characters were kind of it happened, and we're very thankful to them that they wanted to come on camera and give this testimonial to Dozy. There's another case study where we've affected more than 800 successful transfers in one hospital alone. And this was one of our first installations during COVID in IGGMC Nagpur, where we converted more than 150 hospital beds to step-down ICU beds in their connected HDU, spanning across 6 wards. The daily triage that happened in the morning, the reports that were created out of these 150 beds, which beds are high risk, which beds are moderate, and which patients are low risk patients that were identified. Patient rounds or doctor rounds were structured accordingly, and early interventions were triggered based on alerts that were raised by Dozy. And these were almost 800 in approximately 8 to 9 months of time. Not only this, we've even worked with the Indian Army. There was a temporary hospital that was set up in New Delhi, which was called SVBP Hospital. We were given 3 days to set up or convert 300 of these beds into step-down ICU beds, and we did it in 2 days. and we ran a full demo for them on the third day. So Dr. Madhuri Kanetkar, who gave us the task, actually gave us a big compliment as well, that her doctors could sleep because Dozy never sleeps. And this is just the beginning. We've right now established Dozy well in the category of general vital monitoring, patient monitoring, and a basic early warning system or a triaging system that identifies that something is going to be wrong in the next few days or in the next few weeks. And there is a lot of investigation or a protocol that you would need to follow in your general. How would you follow in normally if a patient would directly come to you? So essentially, what we're moving towards now in the next few years, and we've already stepped a foot forward on most of these projects, is essentially going deeper into each space. Cardiology is one of the very important spaces to us. So a couple of research points that we're working on. I already mentioned a non-contact blood pressure that we're working on from the vibration data. Second, we're working on a heart failure project with AIIMS Jodhpur and Jaydeva in Bangalore, where we are trying to estimate the cardiac output non-obtrusively, non-contact from under the mattress even, which is where we're looking at the trend of the cardiac output. So let's say if a patient is at home post a heart failure event, we could track the trend of the cardiac output in every day for a few weeks and look at the trend accordingly. We are also working with some hospitals on sleep apnea to estimate the apnea hypopnea index during the night of patients. Sleep apnea is severely underdiagnosed in the country. And the idea is that we can enable easy triaging and screening for that so that we could identify more and more undiagnosed cases before they come to you. Beyond that, we're also working on touchless arrhythmia detection as well with a few hospitals and a few doctors there. And the idea is that moving forward, we have to reimagine healthcare. A sleep apnea test that looks like on the left should look like on the right. As I mentioned, screening for heart failure, a lot of places in our country do not have access to an echocardiogram. In a lot of rural areas, the nearest echocardiogram is 100 kilometers away. Can we enable smart screening and identifying and bucketing people in the category of, let's say, grades of heart failure so that we can escalate them to the nearest facility to confirm? Beyond that, people who are already at home would not every day go and do an echo test to estimate their cardiac output. So can we do that on a daily basis without bothering them or without changing their life cycle or lifestyle, and ensuring high compliance in the process? Non-contact blood pressure monitoring would actually change ambulatory blood pressure monitoring to something like which is on the left to something which is like on the right. Arrhythmia tests. And the moral of the story at the end of it is essentially that we cannot do this alone as technology. We have to come together, healthcare professionals, along with technology, along with policymakers, along with hospital administrations, and we have to do this together. If we have to leapfrog and solve for the load or solve for the scale that India is. Thank you. Any questions? Okay.